Hi, team. Today we're going to do the finale of the PCR rollout. We started in January with one group of facilities, and there were about 5 people in that group. And so not only were the nurse practitioners trained, but the facilities were trained. And we moved on to February and did another group of 5 and kept that process going. In March, we did 2 groups of 5, and then April and May. And so as we've rolled out, we're 7 months in now, and we're ready to roll this out to every facility. So as of today, every facility would have gotten some training from Ecolab on PCRs. And so what I'm going to do today is give you the education that you need to prescribe and to read and to be able to utilize these lab results so that you are the same as all of the other facilities. The pilot program went well. There are going to be a little bit of hiccups, especially as you try new things in the building. And so if you have hiccups, we'll give you that information. We'll put you on a chat that is specific for PCR testing. So everyone's name will be put on that chat. Today is Wednesday. I'll put your names on it starting Thursday because I'll send out this email today, and then it'll give you a chance to watch this video. But really what we're going to do, and we talk about this video, is I'm going to take, and we're going to go through a PowerPoint. We're going to go through what the labs look like, how to order the labs, how you are going to see what labs should have been drawn in the morning, and then what labs still are pending the next day. Because if something hasn't been sent out, then you'd need to know about that so you could get with the director of nursing or get with unit managers to get those labs ordered. Otherwise, those labs are going to stay pending. Of note, I want to just bring to the attention that all those labs that are in the computer, and they're from last month and the month before and the month before, there is a glitch with Point Click Care and Ecolab. And once the glitch is fixed, we'll be able to go in and delete all of those labs that have been completed. And once they're completed, they actually disappear off of the order listing. So for all of you who have Coumadin and you're doing PT-INRs weekly or every other week, your daptomycins, you're getting labs twice a week, those labs will go away. They told us, Point Click Care told us about August or September. So we're pretty close to that happening. But just know, as I'm showing you how to order these labs, where to find them, that there is that glitch of where they just hang on and you can't delete them or get them out of the computer system. And that is being worked on right now. So let's start. Of course, our infamous or always famous PowerPoint on PCR testing. And we do PCR testing. They're called UTI PCRs. I don't know why. They should be urinalysis, but they're UTI PCR testing and wound culture PCRs. Dan Adar, and I have him on our group chat as well, so you have access to him. And I will also give you his information in the email, is the Chief Operating Officer over Ecolab. He has been the one that has done the extensive education for the facilities. Now, maybe some of those people have since quit and we've got new people. And so there's always going to be repeat education. That's something you bring up to the nurse, director of nursing, unit managers. If you ask for a PCR testing and it's not done and nobody knows what to do, then we'd call Dan and Dan could come back and help educate the DON unit managers. But I'm actually just going to show you the way to do it. It's going to be a piece of cake as we go through this. So molecular PCR for infection, what it's going to do is give us the infection and the resistant detection. So it's kind of like a urinalysis with culture and sensitivity, or it's like a wound culture with sensitivity. It's going to give us what it's resistant to, and we're focused specifically on wound and UTI cases. Now, there may be an opportunity, as we had started in January, for us to do respiratory PCRs. And we did those, and we were getting influenza A, influenza B, strep, and RSV. So we do have respiratory cultures that they do as well. That's not part of this PCR rollout, but if you kept that in the back of your mind, because we're in July, then August, September, we're getting pretty close to getting into flu season. So this specifically is for wounds and urinary tract infections. So why are we going to use a molecular PCR? We're actually going to order a UTI PCR or a wound PCR, and these are to be 100% replaced with the urinalysis with culture and sensitivity and a wound culture. This is what we're using. This is what every building in Aviata is using as their method of collecting either urine or a wound culture. So if you have a wound doctor that says, get me a culture and sensitivity, it is a wound PCR, just so you know. Rationale behind that. There is a high sensitivity, so it detects lower levels of pathogens because it's way more sensitive. You get rapid results. There's a faster turnaround compared to traditional methods. You go in at 7 a.m., you ask for a urine PCR, and I'll show you how to do them, not really on the computer, how to do them. You can literally do them in 1 minute, and then you call Echo Lab and have them come pick it up. From the time it is on the machine to the time it's off is usually about 4 to 5 hours, depending. So if it takes 2 hours for them to come pick it up and to get it to the machine, you will have your urinalysis with culture and sensitivity or your UTI PCR by the end of the day. So no more 3 days of waiting, no more patients turning septic. You actually have those results. Now, a couple of things have to happen. You actually have to order it. You actually have to obtain it. You actually have to send it out and then look for those results. So that's where you are in conjunction with the facility. So there's a much faster turnaround. It's a broad detection, so it identifies not just a normal 7 organisms, but a wide range of pathogens, including those that are difficult to culture or are difficult to grow in culture. So, and then it gives you the resistance detection, which a typical culture and sensitivity would, but it does it via genetic markers for that antibiotic resistance. And then it's suitable for polymicrobial infections. So if you have a urinalysis that comes back and it says that they have E. coli, did it miss the Klebsiella, which might not have been as strong? So this gives you a low, a moderate, and a high degree of pathogens, and you'll be able to see. So it may be able to detect multiple pathogens. Obviously, if it detects multiple in a urinalysis, 3, 4, 5, 6, it's a contaminated culture, and you'd want to do it again. But again, you're not waiting 3 days, you're getting it that day. So again, reduction in turnaround time, it identifies those hard to culture pathogens. When you're looking for rapid diagnosis, your patient's not doing well, instead of transferring them to the ER, let's get them taken care of now. Those difficult to grow organisms, and then it's useful in recurrent or complicated UTIs, while microbiology is often sufficient for routine. So maybe a female, it's her first urinary tract infection, urinalysis might be okay. But these we're using because we're in a compromised environment. We're in a skilled nursing facility. So we would want to use something for more complicated cases. And so I'm not sure if you can see this, but this is the first thing that pulls up when you pull up the results. It does say urinary tract infection by PCR. This is the most important takeaway from here, and this is what you're going to have to do the most education on. So this interpretation shows that something was detected, and there's a high, which is greater than 100,000 organisms. There's a medium, which is not normal. Medium is usually 50 to 100,000. This is 10 to 100,000. And then there's a low, which is less than 10,000 or not detected. So as you're going through a person's results, you can see that this Enterococcus faecalis is abnormal and it's detected at a high, meaning you have over 100,000 organisms there. So that is our result. That's our organism there. And now we have to determine how to treat that. This is the next paper that comes behind. It actually is just this guy right here. Let me see. So it looks like this. And this I've just shown you how to read the report. So first it detects the organisms, and if this is blurry, I apologize, but it has detected 3 organisms at bottom to top: Klebsiella pneumoniae, the E. coli, and then the candidiasis. So that's not bolded, which the 2 that are bolded are the common pathogens that it detected. It also detected some candidiasis. However, there is a little statement here, and that's really blurry, and I apologize, that says that although common, it could be colonized or contaminated, especially in your female patients. So it did detect the 3 organisms, but 2 which are actual organisms and 1 that might not be if there's no symptoms. So then it will go to the resistance detected, your MRSA, your VRE, your ESBL, and it has detected that this patient has ESBL. So any kind of antibiotic resistance, it's going to show up here. And the rate of that is saying there's significant ESBL in this patient's urine. Then all of a sudden it pulls in from point click care your allergies that the patient is allergic to. So you already know that you're not going to do any macrolide antibiotics. So that comes to your attention if that's an option to just get rid of it. It's not even an option. Adverse reaction ARC scores. So there is a potential if you're going to use trimethoprim, that there's a dose adjustment if it's a renal patient. The side effect is going to be hyperkalemia. Why would you need to know that? Just in case we're doing potassium replacement or we're on a potassium sparing diuretic. It's a good thing to know if you're going to treat this patient with this medication, that you need to be mindful of that. And the interactions is the ACE inhibitors. And the adverse reaction score is low. It's 2. So it's not that drastic, but it does want you to be alerted to that. You can scan this code, the QR code, to get this interpreted into different languages. Over here is the amount of complexity that this urine is representing. So on an ARC score, this patient has a pretty significant urinary tract infection. It's not full on high, but it is saying that the ARC score is 5. This is giving you the answer to the test. The number 1 choice for something like Klebsiella and E. coli that will treat both organisms would be, and forgive my lack of vocabulary, I like to look at every generic and just use their brand name. So Bactrim DS, one tablet by mouth times twice a day times 3 days. And then it gives you the caveat for possible simple UTI. So this is the answer to the test. What do you start the patient on? You start them on Bactrim DS. That's your answer. Then it gives you alternating medication. So alternative treatment options, and I'm not sure if you can see this, is macrobid, which we already know we're not going to use. Phosphomycin, one dose for possible simple UTI. I don't ever see phosphomycin being used. It's a packet, you dump it in water and you use it once. I see a lot of it for prophylaxis, but I don't see it for a simple UTI, nor would I see it for a simple UTI on an elderly female patient that was pretty compromised in a nursing facility. But then it gives you Cipro, 250 to 500 twice a day for 3 days for a simple, and it does tell you simple UTI. Then it gives you the option of ertapenem, 1 gram IV or IM. It gives you the option every 24 hours for 5 to 14 days for possible complicated UTI. So then the question that becomes, as you as a provider, what do you want? How many urinary tract infections has this patient have had? Have they only had one, and so maybe 5 or 7 days is sufficient? Or like one of my patients that I just treated, they get one every single month, history of bladder cancer. And so I do the 14 days when ertapenem is my only choice. So if you've got a male, they're automatically complicated. And if you have a female that has had more than 2 urinary tract infections in 3 months, then they're complicated. So just understand the difference between complicated UTI and a simple. And then so in this scenario, the males will be treated with ertapenem, and it would be your decision for the females for the macrobid, the phosphomycin, or the Cipro. Now, just because it says Cipro, 250 to 500 for 3 days, doesn't necessarily mean that's what you have to use. This is not saying you can only use this. You could use it to 5 to 7 days if they had an antibiotic that they were taking last month and they have the same organism, and we had them on medication, and now we're really trying to kill it. So now you're looking at maybe they need a different antibiotic. So maybe they were on macrobid last month and now we're putting them on Cipro, so you could use 7 days. So this, just because it says what it suggested, does not necessarily mean that that's what you have to use. Now then it's saying why would you use this antibiotic, the Bactrim DS, and it's saying that E. coli and Klebsiella can have pathogens when in the urine. However, candidiasis was not targeted since it may be a colonizer found naturally or in a contaminant. So like if there is yeast growing and it's in the container, it doesn't turn dark bold because it could be colonized. And when should this be treated? When should what be treated? When should this candidiasis be treated? So if you have, and this is so important, if you have symptoms, you would want to treat for a urinary tract infection. If there was a random fall and the facility did a knee-jerk reaction and said, let's get a urinalysis, and they did it, and it came back and it was positive, obviously not with 100,000, but let's say 20 to 100,000, then would you treat that? Only if they have symptoms. And so this is a little bit less, how should I say it, messy. This is one that is saying that they detected E. coli, that the patient has an allergy to sulfa. Your goal is macrobid for 5 days for a simple UTI. The ARC score there is 3, so it's right in the middle. The complexity is only E. coli, so there's a low complexity of it. Your goal is some macrobid. However, remember that the best medication is based on simple, here it says simple UTI. Other medications that would be appropriate are here. Phosphomycin, again, never. Augmentin, BID for 5 to 7 days for a simple. Levaquin or levofloxacin for 3 days for a simple. And then now they're saying that they want you to be on something like Zosyn every 6 hours for 7 days. So why is this their choice, one choice? Because E. coli can be pathogenic when found in urine samples, and the sulfa allergy precludes the use of Bactrim DS. So that would be a macrobid choice. When should this be treated and not treated? Well, if they have no symptoms, if it's asymptomatic bacteremia, you would not want to treat this patient. So just know that just because they've triggered doesn't mean that you're automatically going to treat. I think sometimes we forget that if they have a low level of bacteria, 20,000, that if they don't have symptoms, we're not treating them. Somebody ordered a UTI PCR, and that's what came back. So ordering PCRs in point-click care are super easy. I did take a blank sheet of paper, and I am going to go under orders, and I am going to go under laboratory. So when I go under laboratory, I should see a box that looks like this. So then I'm going to continue on with that. It's going to ask me for my password. I'm going to put my password in, and then up comes your order. So you're going to do create new order. And then after you create your new order, there are going to be some common tests that pop up. They have done an amazing job of putting at the top the UTI PCR 29, the UTI PCR 8, the wound infection 27, and the wound infection 8. So here's how you determine. So if you have a complicated UTI, if you've got a male or if you've got somebody that keeps getting urinary tract infections, you would want to choose the 29 target. It would do 29 different organisms and evaluate that. I use that. We're in a nursing facility where a lot of bacteria is. Somebody that's immunocompromised would need a 29 target. Somebody our age and younger, because I'm an old lady, they might do well with an 8 target. But when I order my tests, I order the 29 target. I want to see all of that, all of those organisms. And then the wound infection by PCR, we usually see just a couple of different infections or bacteria, but I always do the 27 targets because you want to be able to have quality information that you give to infectious disease or that you're basing your antibiotic therapy off of. So after you pick whichever order you're going to use, then you're just going to save it, and that's going to be how you order it. So these guys right here at the top. The facility manifest report. So there's an attached facility night shift report. I actually didn't attach it anymore. They should know how to do that. We're not in the pilot program anymore. Oh, it likes that. So to do a manifest report, and this is where I want you to be aware, because just because the facility is doing the manifest report does not mean that you should not be doing the manifest report. So you're going to go back into the lab section on any patient, whether they have labs ordered or not. So any random patient, you get into the Eco Lab, you sign in, and on the top right-hand side, there is something that says Manifest Report. When you click onto the Manifest Report, it will show you that you can do a new manifest. I just so happen to be in Palmasola. So on the left-hand side, it's the only thing on the screen. It shows you the facility. You want all units, Ecolab, and then the start date and end date. I would say your start date for Monday and your end date for Wednesday. And when you print your manifest report, it's going to give you all of the labs that are due. So it will give you something that looks like this. And obviously for HIPAA reasons, I cannot show you, but it will show order manifest report. And let me see if I can do this without compromising HIPAA. It will give you the patient's name at the top, and then it will give you what labs are due for that day. So this is the reporting period, June 28th to July 16th. I just picked a random date that was already entered in there. So it's saying for this patient whose name is right above here that they have a CBC, a CMP, hemoglobin A1C, a lipid profile, and a TSH. And it literally lists page after page that you can scroll. So you print that, and as you're in morning meeting, you check off, and then you're like, wait, I didn't get the results of this lab from yesterday. And then you give it to the DON, or you give them the name. I wouldn't give them your manifest report, because at the end of the day, you want all of those labs that were ordered to be done. If they weren't done, you have to reschedule them. So that's a big deal on running that manifest report and getting that information. Who clears the lab orders? We're working on that. That was the August/September we're not sure about yet. So we'll figure that one out as soon as, I can't delete that. As soon, oh, I can. Okay, as soon as Point Click Care and Echo Lab get together. On your manifest, or on even just on your order sheet, any order that says pending or that don't say sent. So if you see something that says this, electronic order sent to Ecolab, we're good. Auto send, it's sent. So that means they've gotten that, and I can actually see in this patient's report that they've got the boxes, so the labs have been resulted and they're in there. But if they don't say that, if they say that they're pending and they're past when they should have been, and I'm looking to see if I can see any of those. So this is a good one. Nope, it's not. I was going to say it says that it's still scheduled on 9/19, but that's for this year. So great job on that. So PCRs are to be picked up after the routine labs. So they come in at 4 or 5 in the morning, they do the routine labs. They are going to leave without your PCRs, even if they're in the fridge. So if you put them in the fridge, they get them later in the afternoon and they choose not to call, they are going to leave them. They drop off their labs, they're back in your building by 7 or 8 a.m. So they will come back to pick up your PCRs. Again, 4 to 5 hours on the machine, which means within a one shift period of time, you will have the results. If you need the PCRs to be picked up, you add it to the Ecolab system and then you call it in for a pickup. And so as soon as they get it, they put it on the machine and they get it done. There has to be some clarification with stat labs. Stat labs are not PCRs. If you order a stat lab, they will come in, they will draw a stat lab, and they will get it to the hospital. Those are not PCRs. PCRs are not stats. So you would not call in a stat PCR. I do have this. I will be sending this out to everyone. This is the workflow order on writing the orders, just the stuff that I went through. It talks about how to send the routine orders, a stat order, nurse collection, etc. So this is where I kind of showed you where I walked through, and you go to the laboratory and then here you are. You're going to push continue. Then you're going to put your password in and it's going to bring you here, which this is the manifest that I showed you at the top. This is how any patient, whether they have a lab or not, any patient will give you the entire list for the building. A manifest report is located in every patient's record. But you can see that these are the labs that were sent to, and then what is pending. In order to create the order, and again, they've moved those PCRs here to the top left. You're going to click the orders and then scroll over and find whatever you need. If you want PCR, respiratory PCR, influenza PCR, whatever, you can look for all of that. Labs are able to be looked for. If you're putting the order in, then you're going to communicate it by you being the primary. You're going to schedule it for tomorrow. The times have been discontinued out of here. They don't use times anymore. So you just schedule it for tomorrow and they come in and run it in the morning. And then you just click OK. And then you're going to send to the lab. Now, you don't have to send to the lab because they're doing a manifest report every night at midnight, and they automatically do it. So no more sending it to the lab, printing off your requisition, putting it in the lab book. Those days are gone. They print the manifest report at midnight. Again, if they don't know how to do that, you can tell your DON, and your DON will help get some more training. One other thing I wanted to show you is that we have a pathologist that works for, well, not we, but Ecolab has a pathologist that actually works and has created this system. So this is a report that you can get if you call the pathology department, and they can see what the pathogens are. They can see that this is resistant to fosfomycin, and then the list of what is appropriate for that pathogen. So there's a list of them. Ceftonir is good for E. coli or Enterobacter. Wow, I don't even know what that word is. Safe for most penicillin allergies. So this is something we have access to as well as the pathologist. And all we have to do is call the pathologist up and get that information. One thing I want to show you. Under ecolabgroup.com is amazing for you to show the nurses, because then you don't have to do anything else. There's instructions for collection. There's requisitions, which we don't need to do. We're doing them in point-click care. And then there's even point-click care training things. So if you just say, hey, will you put in a PCR UTI? And they're like, I have no idea. This will train them. All you have to do is say, go to ecolabgroup.com and it will give you the training. You can even pull this up for them and then walk away. It gives you how to do the manifest or report at nighttime. If the DON says we've never been taught that, you can just pull this up and just go to testing resources. So here's training videos that is what Dan would be doing. Instructions for collection. So this is simple. If they say, I don't even know how to do that, or the patient's incontinent, you've got a UTI brief collection and a cup collection. So you're going to take the least contaminated part of the brief. You're going to swab it with a swab, that area, it's usually in the front. You're going to take the swab, you're going to snap it in the jar and put the lid on it, and bam, you're done. So when they say, the patient hasn't urinated and that keeps going on for 4 or 5 days, this is it. Like, all you have to do is find the wettest area in the brief and the least contaminated. And then you can get the brief one. If they're continent, you put a hat in the toilet, then you can dump it into a cup, and then there's your specimen right there. So this is like stuff you don't even have to explain. You just come on here, show them, and they can figure it out themselves. There's videos as well as the step-by-step. So this is for the wound specimen. So it tells you cleanse the wound first. So that's the most important part. Don't get the gooey stuff. You want to cleanse it first. Then you're going to collect it, transfer it to the tube. So if somebody says to you, I don't know how to do that, you're going to go to ecolabgroup.com and go to the testing resources, and it shows you all of that. So simple, Simon. You don't have to do any training or education with the staff. It should just be right there for you. Glad that you guys are now part of the pilot program. We're officially completed at this point. I will send all of this out to you, and I hope you guys have an amazing day. Let me know if I can do anything to help you.